Yeah, good morning, Dr. Srinivas Kumar and all the panelists. A very good morning to all of you. So the way we'll do it is we'll just have Dr. Anuj present the case first, and we'll take opinion of the panel. We are about halfway into the case, so once we get opinion from the panel, then we'll proceed. So over to you, Anuj.
Good morning.
Can we have the slides, please?
Sir and everybody on the panel. So this is a 65-year-old gentleman. 2010, we had stented him in the LAD for his TMT, which was positive, and came back. He used to come back for regular follow-ups. 2013 had a ACS. We stented the RCA then. Has been stable since then. A week ago, basically had sudden onset chest pain with shortness of breath and diaphoresis. Troponin was positive. Did the angiogram, and ECG was normal. Echo was normal. And this was the angiogram. Left main shows a tight stenosis. The LAD looks okay with an ISR, focal ISR in the mid LAD. LCX is a small vessel which is totally occluded. Ramus was again a narrow angle takeoff with a mild disease in the ostium. The rest of it looked okay. RCA again had a focal stenosis in the proximal part of the stent. So the issues here again we had were the significant diffuse left main stenosis, occluded small native LCX, a narrow angle takeoff of the large ramus with mild disease, and a focal ISR of both the LAD and the RCA stents. Now, whether bypass versus PCI, the golden question as ever. We did the syntax score, which was 32.45, and the syntax 2020 was almost similar for both. We had a discussion of the heart team. We included the patients and the family as well, and they opted for PCI. So now the discussion is about RCA first or left main first, IVUS or OCT because of the ostial left main involvement, lesion modification strategy, and whether we use DEB versus DES for the ISR. So we actually started off the case with the right. We injected the right, but it was
so while Anuj just tells that, I'll introduce the team. So of course, Anuj, everyone knows, we have Dr. Uday to my right. We have a senior nurse, Kantama, and beside her is Dr. Neelkant, again a senior cardiologist. We have technicians, Kiran and Ashok along with us. So all of them with probably experience more than any one of us. So over to you, Anuj. You can tell us what we went through. So we thought we'll start off early, finish the RCA, and then take opinion from the panel about the left side. But Anuj will tell us what we went through.
So actually, RCA, ostial RCA stenting, it was very difficult for us to engage and have a stable thing, and we were getting a little short of time. So we switched over to the left. And we'll tackle it after the live is over. We'll tackle the right. So this was the left, as we saw the angio as well. Now there is an ostial LAD and a diffuse left main disease. We passed a BMW wire and we did a run of the OCT, which showed a very focal 12 millimeter ISR of the LAD in the mid. That is exactly at the overlap of the two stents of the LAD.
Can we have the first run of OCT?
Yeah, we're seeing it now. And
so
first
of
all, I think it was a great case. Thank you for showing it, and it's great to have you transmitting here. You know, the first thing is just it just jumped out to me from the beginning, and maybe the post-dilatation balloons from the prior intervention were different, but generally speaking, you know, 2.5 stents in the LAD and 2.75 in that area of the right coronary artery. I would be thinking that perhaps these are just underexpanded all along, and that may change your management. Also would favor for me a strategy of repeat PCI versus cabbage, because if you did a really best job and the patient restenose, that's a different situation than if you potentially have underexpanded stents. And I might give the patient another shot now with imaging guidance as you're doing at this point. So sorry, keep going through the OCT. We can see it.
Yeah, absolutely. We thought as well. That's the reason we actually ran the OCT first. Stent actually surprisingly seemed pretty well dilated.
Yeah, a lot of new intima though in that segment.
And yeah. And the focal stenosis there, and then at the ostium of the LED was tight and the left main also was tight. We decided not to touch the LED, the left main initially. We pre-dilated the focal ISR with a 2.5 15 balloon first, then did a cutting balloon with a Wolverine 2.5 10. We went a little high pressure, did a couple of dilatations there, and post-dilated again with a 2.75 15 and ran the IVUS again, the OCT again, just to see whether there is any dissection, whether we should here change our strategy to have a DEB versus a DES. And I think the IVUS run, the OCT run post, can you just run the second?
Yeah, go to the next one.
So, Dr. Ramesh, the issue here was whether we should go ahead with complete stenting from distal to proximal. We had a diagonal there, which might have issues about jailing because the wire might get entrapped between two stents. The issue about size mismatch between the LED stent and the left main post dilatation. So our general pre-procedure planning was if we can get away with a focal depth in the distal LED and do a proper job from left main to the proximal LED, then probably that will give us more comfort. So we thought the decision on depth versus DS we'll decide after the OCT run, once we have made the lesion preparation. And that's the OCT which is being run after cutting balloon and 2.75 post dilatation with NC balloon. So I think we can take comments from the panel, and then what would be your strategy? What would you want us to do?
Yeah, good morning, Rajeev and Anuj. This is Ajit here. So it's a nice case, and what we can see basically is focal areas of in-stent restenosis, which seems to be a well-deployed stent, but focal in-stent restenosis in two areas, apart from the left main disease and the ostral LED disease. So I would agree that we need to debulk the lesion first, and I would use a cutting balloon up front. 275 is reasonable. Wolverine seems to be good. And now we need to look at the OCT to decide, have we got the intima away? The lumen, is it enough? And do we need a DEB? I would restrict my stent as much as possible in an area where if the lumen is good.
Can I ask? Yeah, go ahead.
Yeah.
Can we have the OCT running, please, on the live?
The ostial diagonal also is diseased, and it's a fairly sized vessel, so we didn't want to actually go up front with a regulating stent there. We thought if we can get away with a DES there, I think DEB would probably have lesser layers and probably have a lesser chance of occluding the diagonal.
So good morning, here's Dr. Ferenc from Germany. So I think also good case pre-selection. So I think, can we see again the left main? Can you recognize a lot of calcium in left main? The question is, can we go here with additional lesion preparation like shockwave? Maybe this could help, or do you believe direct stenting or stenting after predilatation with NC balloons with some good radial forces stent will be enough?
Yeah, I think when you're approaching the left main, that'll certainly
We looked
be
at the left.
important to tell. The one thing I'm concerned about, though, personally, though, is, you know, this is a LAD that wraps around the apex and has a diminutive circ. And the lesion, the areas that you're looking at with the OCT, you can't, you know, because of the depth of field, you can't actually see the actual size of the vessel as well. And I personally would be very surprised if this is not at 3.0 or even 3.5 in the proximal segment. And I feel that one of the reasons that this may have happened in the first place is because the entire thing is systematically undersized. It looks reasonable based upon your OCT, but we don't really have a very distal reference segment. So do you have the OCT image beyond the stent where you could sort of measure EEM to EEM? Because in that mid-LAD, it looks to me at least like a 3.0-ish type of vessel.
I think in general, if you study medicine
distal,
and have
EL to
anatomy courses, you will see the proximal LAD is in average a minimum 3.5, something between 3.5 and 4.0. So that's why if I see sometimes 2.5 stent in proximal LAD, this is a terrible situation. This is really undersizing.
No, so I know you're trying to draw a length where the stent is. What I meant is that in the first run, do you start distal to the actual stent itself? Because wherever there's a stent, it's very challenging to appreciate the true vessel size in the stented segment.
Just go 2 millimeters behind distal to the
On
LAD.
the first run. I know I don't want to belabor the point too much.
We did that measurement, and it was around 2.47, around 2.5 distal to the stent, the first measurement which we took.
Yeah, I mean,
2.48 was the measurement which we got distal to the stent.
Can you go and show it though on the first run? Because I don't see that there's still stent there.
Yeah.
I don't see
First run go distal to the stent.
the very first run.
Yeah, we'll show that.
Yeah, there's mostly stent through this whole segment. There is maybe a little bit of segment down here where you don't see it, but it's tough to know. Is it underfilled? What's going on? And I don't really see a great EEM at that segment. So I don't know. I think my only concern with this case is that I'm trying to prevent this young man from, or this gentleman from having to come back again. There you see it reasonably well. Yeah, so, you know, if it's 2.5 down there, and remember, OCT is going to be pretty accurate, then in the segment you're looking at, it should be, especially because there's a diagonal there too, it should be at least 3.0 and bigger, even more proximally.
Yeah, I think proximal will be 3.5 normally.
So I might take a 3.0 non-compliant through that entire segment and then take a 3.5 proximally, and you'll get better stent areas, and then hopefully you can just use a DEB for the focal area and then stent the left main with whatever you need to stent.
I would also suggest to take now at least 3.0 for mid part and 3.5 for proximal LAD, and then check again with OCT. Yeah, you can do this for sure.
But go ahead. I don't want to talk too much.
3.012.
3 into 15.
I think if you go by the Lumen 4 criteria, possibly the proximal would be definitely more than 3 from what you see. And the distal looks 2.75 in my opinion. But the proximal I would definitely go up to 3 and then take some measurements of the ostium LAD and left main and then see how to debulk and what to do.
Rajeev, this is Srinivas Kumar here. I think you can proceed with your plan with valid suggestions, but you don't get...
yeah, exactly. Don't get sidetracked by it.
Because you go ahead with the plan, procedure, and final result should be good finally. Go ahead.
Yeah. And I think in terms of your strategy, doing the right first makes a lot of sense because you get that out of the way. It's a big territory. It makes the left main intervention safer. So that strategy that you chose was right. I think that your strategy to deal with all of this with the most provisional approach, try not to close the diagonal again, all that makes sense. So those are, I think, really important fundamental concepts for this case.
So we almost landed in a situation where probably the live case we would be showing guide engagement of the RCA. So.
I've done it myself, so I can relate.
Yeah.
And this is an NC balloon?
This is NC balloon. This is which balloon? Quantum. So we were a bit worried about pre-dilating the left main before we are sure that we finish the job distally. We really don't know how that left main is going to behave.
Yeah, that's a good teaching point too. Many people think that they should, optimally predilate the left main, but if you have work to do distally and then you dissect the left main, you get in a lot more trouble. And so unless it's super tight where you just have to make a little bit of a channel to do your distal work, I agree with that strategy completely.
Very important additional point is just to observe how the pressure is, how the hemodynamics are, and you have now very stable conditions, so you can go ahead and first try to manage the mid part and proximal part of the LAD, and then focus your attention to the bifurcation, distal left main bifurcation lesion.
Now, by the way, I think
after the 3 pre-dilatation, probably the proximal LAD looks around 3.5.
yeah.
I think we'll just do a depth distally and then put a stent proximally with a 3.5. 3 depth.
Yeah. The clues to this are really the wraparound, the fact that the circuit is small, that can help. But I think that your hesitancy was right, because just at that segment of the LAD where it goes down, that's often where there are bridges, and that's often where perforations happen. So I think that's a good reason to be cautious, but you also have to, especially in somebody who's restenosed, get the best result you can.
So the important thing, which I'm not sure if it was discussed in the previous live, but it's important that this is just a drug delivery balloon rather than a drug coated balloon. So we find many times when people are trying to dilate the stent with the DCB, which should never be done. So we did the 1:1 dilatation, and so 3O balloon and 3O DCB.
Yeah, that makes good sense.
Do you have paclitaxel coated drug balloons or sirolimus coated balloons?
So what we have is a sirolimus coated balloon, the Magic Touch. I think if they can, yeah, I think you are able to see that.
Yeah, okay.
So we generally use the Magic Touch balloon. And
Ajay, I think this is a limus coated balloon,
Yeah.
which is not there in US, and many of the centers started using this, especially when you're facing this ISR type of situation, and then diffuse disease where you can't stent it, and then we're trying to find newer indications too for this, but data is lacking. But the great help. Only problem we face is if we need 2-3 balloons in one patient, it's a little more expensive than a stent in that country.
Yeah.
That's what we are trying to talk to the company to
Yeah.
devise a package for one patient. I think.
Actually, I mean, we suffer.
so we
greatly
generally tend to
in-
keep it for 45 to 60 seconds.
Yeah, and that's why the hemodynamics are important.
Based
that
on how the
with
patient
circ
tolerates
occluded, sometimes with the right open, this will be tolerated better, but I suspect he's going to be okay with normal function. The only thing I would say is that in the U.S. we really suffer because we don't have any drug-coated balloons aside from the peripheral ones, and so we're randomizing in a study comparing DEB to POBA alone,
Stent
and
boost.
hopefully that
Stent
study will
boost.
complete enrollment relatively soon. But blood pressure looks totally fine.
I just had a question for the panel regarding the issue about strut fracture. Do they feel that more than the imaging, either OCT or IVUS, just a stent boost and fluoroscopy, that helps more in trying to identify a strut fracture?
Yeah, it's a great question. I think that can certainly help. We're spoiled in our lab because we have Akiko who's there, so she can always tell when the stents are overlapped and intussuscepted. You can get better at it over time, but I think you have to use all the tools, the fluoro, the stent boost, the imaging, and then also is it on a hinge point?
So I think all modern cath labs have this option, clear stent or stent boost, and at least in our cath lab we use this very frequently, and it's very helpful to understand the length, to understand expansion, even if you check this into different projections.
So it looks like the other site is ready. So
3.524.
what were you planning to do for the left main?
So we thought we'll put a 3.524 and go with a provisional strategy. There is a osteal disease in the ramus, but we would like to keep the metal load as less as possible. So the plan is to go with a provisional strategy, do a FKBI, and then take a call whether we should put another stent or not.
I think this is very clever approach and very wise approach. So would you go now with pre-dilatation 3.5 for left main and then put 4.0 stent from proximal LAD?
Yeah. Yeah.
Yeah, yeah.
I think he can continue to work in peace. Rajeev will go to the other center and come back to you in 20 minutes.
Yes.
Yeah?
Oh, that sounds
Yeah,
great.
sure.
Thank you. So this is a
Definitely,
super
definitely,
interesting and fascinating case. Thank you.
Yeah, yeah.
Anuj, Rajeev, we can see you. We are back with you now. Okay?
And Anuj, I promise to talk
Yeah,
less
yeah.
so you can do more.
Yeah, thanks. Yeah, so
yeah,
Anuj,
go ahead,
what-
go ahead.
Yeah, so after you left us, we went ahead with stenting of the left main, ostial stenting, and then we post-dilated with a 4 and 4.5 mm balloon. And then can we just go to the last shot, the LAO caudal and crane? Yeah. So here we thought that the stent is well expanded and ramus seems to be flowing well, patient is stable, there are no ECG changes. We thought before we do a FKBI, we'll take a call based on the OCT. So we tried to go with the OCT, but the OCT was not going through, so we used a guideliner. And after using the guideliner, we were not able to inject properly with the OCT. So we thought we'll just do a IVUS run and then take a call. So again, would the panel recommend a routine FKBI because this is a ramus, or would they base their decision on imaging or not do anything at all?
You know, it's dealer's choice. The only thing that would make me more inclined to do a kissing balloon or a further dilatation is the fact that the OCT didn't cross. Because that, unless there's wire wrap with the ramus wire, makes me worry that there's something lifted or something strange, because to not be able to cross from the left main into the LAD would be a little bit odd.
I think for the future, you have a small circle occluded, and the ramus is important for this patient. So I think for the future possible attempt, I would go here with final kissing. Pot, final kissing, final pot.
But what did you do? Show us, because I promised not to talk so much.
No, actually, we are just doing IVUS run to see what exactly is happening.
Okay.
And then probably recross the LCX and do the FKBI and a final pot. So that's the plan. We thought we'll just image to see if everything is all right and then go ahead with the final plan before we image in the end.
And so the IVUS will be through the guide extension or not the guide extension?
No, through the guide we are just trying.
Just
And,
the guide, okay.
If it doesn't go, I think we'll use the guide extension.
Yep.
Floro? Yeah, so
Very
IVUS
smooth,
slipped in.
very smooth.
Okay. Yeah.
This happens in times with the OCT because the catheter at the junction
Yep.
sometimes has
Just
difficulty.
check the IVUS
yeah.
images. Yeah.
Can we see the IVUS image? This will actually be interesting too, because you'll now see what this distal vessel, distal to the stent, looks like after you've dilated and such. Yeah, so here, to me, and again, IVUS overestimates a little bit, but now beyond the stented segment, it's looking 3.0. In fact, maybe even bigger. So that's, I'm glad that you took the 3.0 in the mid and 3.5 proximal. You see how, so some of this is all just filling. It's just flow, filling, and beyond, and that's why the OCT can sometimes be a little bit misleading if you don't get a true EEM segment.
Sometimes vessel distally could go into spasm. That's why treatment with NTG also becomes important.
But once again, back to the basics, LAD proximal has practically always 3.5 diameter, mid part minimum 3.0, and distal LAD is 2.5.
Yeah, proximal.
This is the ISR segment.
And the 3.0 looks perfect for this
No.
throughout.
Yeah.
Yeah. It looks well expanded, and I think the lesion preparation also looks good.
Doesn't have too much of a neointima either right now.
Can we keep showing the IVUS images, please?
Yep, we
Right?
can see them both together.
IVUS image.
But what they did just now, really important, coat register, step on fluoro when the IVUS is there, because if you see something of note in a long run, you'll not know where it was unless you step on Cine or something.
Yeah, so we are now coming to the proximal stented segment.
We are near the diagonal actually right now.
So vessel's almost 4.0 here.
We can. Yeah, so we post dilated with 4.0. The ostial LAD also we dilated with a 4.0 balloon.
Can you show both the angio and the IVUS?
Fluoro and IVUS, please.
Simultaneously? Yeah.
So now coming back to,
This
there
is
it
the
is,
left
there's
main
the
here.
ramus that just came in, I think.
Yeah, so we are in the left main
And there's the guide.
okay.
So what do you think?
Yeah, so generally our practice is to do a routine FKBI for all left main diseases, especially if there is osteal LCX disease. But here it's more of a ramus, and I think it can go either ways.
I would probably
do
do it.
FKBI and land up with a dissection probably will be complicated.
Yeah, I think I would
So
probably
Anuj
do
has
it.
already taken the wire, and
Yeah,
think
I
he's
would do
ready
it,
to
but not be
recross.
too aggressive. That's all.
You probably take a 2.5 balloon.
Now remember, the diag is small, so this is basically his entire lateral wall is this ramus. So I think that your instincts serve you well.
So as I suggested, I would definitely go in our cath lab with kissing for ramus, for sure.
So I think
So
Anuj
generally
is trying
speaking,
to go
he's-
distal and try to
You have
get the
definitely
most
now
distal,
tried to cross very distal strat if possible.
Yeah.
This is easy to say, but
Yeah.
finally I think you
So-
make nice progress. I could imagine you need first of all as next step to take 1.5 balloon
2.5?
just to open the struts, and then 2.5 and 4.0 for kissing.
You can take the 2 balloon. Yeah.
So that technique is really
So
important.
we have a 2 balloon, so we'll just see if it can just open.
So distal strut, small balloon, and then go. That's kind of the best way to do it.
We'll do a FKBI with 3.5 and 2.5.
Yep. And then if the balloon doesn't cross into the side branch, you can always inflate the balloon in the main branch to anchor the guide and then go. But I actually
Yes.
don't push too hard. If the balloon doesn't cross easily into this ramus, then I would almost then pull the wire back and cross into a more distal strut rather than try to disrupt the stent.
I think this is important information. One more option will be to take a bit harder wire. So sometimes you need intermediate or access support wire, and then you can cross with the balloon much easier. Or even you can do IVUS guided crossing, or even you can check the wire position with OCT. So you have a few options.
Dr. Ferenc, which is your preferred most low-profile balloon when you have difficult situations like this? What is your preferred most low-profile balloon for crossing?
Low profile, we have in our cath lab Ikatsuke and Rui from Terumo,
Yeah,
and
we use that radial from
Sapphire
Thermo,
as
that's
well.
pretty useful. It's called as Ringen Place before.
So previously we used to recross with hydrophilic wire, and as was mentioned, I think using a workhorse wire and it crossing comfortably gives us that confidence that we are not going through a dissection flap or something in the side branch.
Yeah.
So
why
many
seems to have gone
colleagues
in
are
comfortably,
trying
but there's
just to
some
go
difficulty.
with 2.5 and C balloon as the first step, and this is in many cases wrong decision, because then you push too much and you make some stand strut distortion and you damage the stand strut.
So that's very
It's-
nice.
We can see you 1.5 balloon crossing quite easy. So you make now a channel, and the next step will be to take probably 2.5.
And what a difference, because that first balloon made it look like it was behind the strut in the left main.
2.5.
And this one just crossed nicely, so I think it's a good demonstration.
So
Well, I think we're
1.25,
running out of
range
time,
in
so we're
class.
going to leave you both and your whole team and then go back to Kirti. But I just want to say, super interesting case, very elegantly done, thoughtfully with imaging guidance. To me, that demonstration of the distal vessel, the first OCT and the second IVUS, really is a good thing to see, because you can see that you might undersize stents that way, so that's good, especially for somebody who you're considering cabbage. You have to get those types of outcomes, and I think he's going to do very, very well with what you've been able to do today, saving a stent in the mid to distal. So thanks to you and your whole team for broadcasting.
Thank you so much.
Thank you.
Yeah, thank you, Rajeev and Anuj.